With a syringe barrel over the contralateral canine, or adjusted mesially or distally according to the flare of the tragus, the needle is advanced through the mucosa just medial to the previously palpated deep tendon of the temporalis muscle. Normally, the insertion point is slightly distal to the maxillary second molar and at the height of its mesiolingual cusp. A few drops of anesthetic can be injected as the needle is advanced to the 2.5 centimeters until bone is contacted. When the needle impinges on the condylar neck, it is felt as a solid stop, in contrast to a glancing contact. Once the target is reached, the needle is backed off the condylar neck 1 or 2 millimeters. Aspiration is performed, and the entire content of the cartridge is injected over a 1-minute period. The patient is then cautioned to keep the mouth open for 30 seconds after the needle is withdrawn. This procedure is thought to help spread the anesthetic solution and minimize the distance from the injection site to the nerves of interest. Typically, anesthesia occurs within 5 minutes after injection. When properly performed, the Gauge block offers some advantages over the standard inferior alveolar nerve block. Because the anesthetic is deposited high up within the pterygomandibular space, it is less likely that various branches of the mandibular nerve, which may provide anomalous innervation of the mandibular teeth, will escape being bathed in anesthetic solution. Also, fascial barriers to anesthetic distribution may be less problematic than with the standard injection. In contrast to the inferior alveolar nerve block, however, anesthesia is unlikely to be achieved with the Gauge injection unless bone is solidly contacted at 2.5 centimeters, plus or minus 2 millimeters. Two reasons commonly account for failure to encounter bone at the proper insertion depth. First, the clinician may have positioned the syringe improperly within the plane of insertion. If the angle is too great, or the insertion point too lateral, bone will be hit prematurely. It is also possible, though unlikely, that the needle will pass through the sigmoid notch of the ramus without striking any bone at all. Bone will not be contacted either if the angle is insufficient or the insertion point too medial. Correction involves ensuring that the point of insertion is just medial to the deep tendon of the temporalis muscle and appropriately reorienting the barrel of the syringe. For instance, if the insertion point is correct but bone is contacted prematurely, then the needle should be partially withdrawn and the barrel of the syringe moved mesially along the contralateral quadrant before reinserting the needle to the final depth. A second explanation for failure to contact bone is that the patient's mouth is not open sufficiently for the neck of the condyle to rotate downward and translate forward into the plane of insertion. If the patient cannot perform this task because of trismus, then the Gauge block should not be attempted. Instead, the closed mouth technique may be considered.